Okay. So we're back and we are finishing up, hopefully today, unless this is part 4, we might end up with part 5 on our basic male hormones.
I don't think it's recording, Dr. Clearfield.
It's not. Okay.
Yes.
It says it's recording.
Oh, it is? Okay,
Yeah.
I'm sorry. I usually get a notification, but
Yeah,
my
no, I got a new app on here and now it doesn't talk.
oh, okay.
It
Okay.
says it doesn't do that. It doesn't do that anymore. So,
Okay.
okay.
Yes, sir.
So, part 4, we're going to talk about basic male hormones. So where we left off, we were talking about treatment of low testosterone without using testosterone. And if you remember from our series on where we did that in a sort of a congealed manner, that we had 19 different remedies, including boron, and including maca, and including lacuna pruriens, and magnesium, 10 milligrams per kilogram, zinc, 30 to 50 milligrams per day. So there's, any number of ways to boost testosterone without using testosterone. These are actually more direct. The first thing we're going to talk about is clomiphene. So clomiphene is a SARM, as you know, and it is a bit of an anti-estrogen. And we've used this for a long time. And what it does is it drives your body to make testosterone. It increases LH and FSH, and on average, a 50 milligram tablet will increase testosterone levels in about 4 to 6 weeks by 50%. So 2 pills a week will increase levels by about 100%. Remember, our goal usually total is 700 to 900, free 2 to 4%. And the free androgen index for males is about 50 to 110. You remember how we calculated that, correct? Total testosterone divided by the product of 0.288 times the sex hormone binding globulin. Normal is 30 to 130. Our goal is about 50 to 110 to 120. And that's sort of where we want to live. Clomiphene has been around a long time. It was developed for female infertility. The dose is 1 to 3 tablets a day for females for infertility. For males, it will drive your Sertoli cells to make sperm. Remember, FSH at the S is Sertoli. FSH will it will to make sperm, and it will drive your Leydig cells, LH. That's the mnemonic to remember which one drives which to make testosterone. And so it's pretty reliable. The big issue lately has been that for the past year, the generic makers are out of business. And so we used to be able to get it for about 60 or 70 cents a tablet in the generic form. We'd get 30 of them for about $25 at with the supermarket pharmacies or a Costco or Sam's Club. And now we can't get it there. You can get Clomid, which is the trade name. And in fact, I've been getting in the mail cards from some company that bought Clomid, and now it's available. It's about 10 or 12 bucks a pill. So we actually have one of the compounding pharmacies. We were getting it from Anazao, and they'll make a 45 minutes, and they have to go off label, so off dose. So they'll make a 45 milligram tablet, and we've seen no difference. And they're charging us $2 a pill for that, so $4 a week will double the testosterone, and maybe $10 for shipping. So they'll send you 17 of them at a time. So I'm sure you can get the other compounding pharmacies to make it for you also. But I've had a long-term relationship with them. So that's what we've been doing. Okay. So what you're looking at here is clomiphene inhibits the negative feedback on hypothalamus. It increases the LH and FSH, on average doubles the testosterone levels with 2 tablets per week. The other advantages is it does not affect the prostate, and it does not affect sperm count. So you can use this when you have those issues. If they have prostatic hypertrophy, testosterone, again, we've gone through this in any number of times, does not cause prostate cancer, but it can enlarge the prostate. The clomiphene doesn't affect it. And so we use this quite a bit. The other product the other substance we use is HCG. That is an injectable, and that's quite a bit more expensive. And a lot of times patients will have to use their insurance because it can go a couple of $1,000 for a 10 cc bottle, at times. And most of the insurance companies, they could care less. So what you're looking at here is, so we had this patient. He was 26 years old. He went to Cancun. This was actually a number of years ago. He went to Cancun over Christmas break, and he got food poisoning. He shows up at my office. His parents were my patients. He shows up at my office in March, so about 3 months after his food poisoning, and he's got Hashimoto's thyroiditis now, which was new. Which, food poisoning, if you'll remember when we talked about that, is one of the triggers, one of the root causes, Yersinia. So we got that under control, and then he kept saying he was still tired and he was still fatigued. He was only 26 years old, and it turns out his testosterone levels were about 200 total, and his free was about 0.6. So again, young men under age 40, you don't want to use testosterone. It will kill sperm, and these guys want to have babies at some point. Most of the time, the sperm will come back once you stop the testosterone. It could take up to 6 months, but I think it's 5%, 6% about, it doesn't come back, and there's really no way to tell. I mean, there's maybe a genetic test you could do, but there's really no way to tell. So there's enough other reasons why they can't have babies if they want to have them. But this should not be one of them. We know better. Okay. So we gave him clomiphene, and his testosterone went up to about 700. He was feeling pretty good. And then for whatever reason, he goes to a urologist. And this was the note I got. That's what you're looking at here. So the urologist says, it was a telephone conversation. I reviewed the test results. His MRI pituitary was normal. By the way, this was before I did prolactin levels on everybody. So the first note I got was that you didn't do a prolactin level. You got to get me on something, right? Well, we do this, as you know now. That's part of our routine. We do this on everybody now.
Right.
Thyroid ultrasound is consistent with Hashimoto's thyroiditis. This was a big revelation. I mean, I think his antibodies were like 500, his TPO. All right. So we discussed treatment options for testosterone. I remember, this is a board-certified urologist. I indicated that clomiphene that he has used and has had a success with is not FDA approved. That's true for this purpose. We do not know the long-term side effects. Well, let's take a look at the next slide. Outcomes of clomiphene citrate in young hypogonadal men. Long-term follow-up of clomiphene citrate for HG shows that it is effective and safe alternative to testosterone in men wishing to preserve their fertility. Okay, and here's the reference. So that took me all of 30 seconds to find, right? What did he say here again? We do not know the long-term side effects, right? Here it is. Okay, long-term side effects. So we got that one, right? Also, will likely preserve his fertility. It is available to him and may be the most convenient to use. Also, will likely preserve his fertility if that is currently intact. Exogenous testosterone suppresses his testosterone and spermatogenesis, which doesn't mean it cannot recover and be stimulated by HCG. These are all unknowns. Also, it is not a good idea for a young man his age to go without testosterone. He feels chronic fatigue and complete loss of libido. Now, here's the next line. Now, remember what he just said about testosterone, right? And using it for him. I offered to get him another opinion with another endocrinologist or at a medical center. I also offered him to send him to a urologist for subcutaneous testosterone implants and also consultation. He will consider his options. Well, we've been doing testosterone implants for how long? 20 years?
Yes, sir.
right? And didn't he just say that this is not what you don't want to use testosterone?
That's right.
Yeah, well, here you go. Okay. All right. So here's a study. This is actually 10 years old. Oh, that's the latest by AMG. AMG was said that they have to have references now have to be within in no older than, they have to have at least 3 references no older than 5 years old. That's the latest from ACCME. So I'll have to go back and find some newer ones for some of these. Okay. All right. HCG is a prohormone. It creates an anabolic state. It balances catabolism. It increases testosterone, preserves the testicular size and sperm count. It promotes weight loss. It increases LH, FSH, and TSH. That's what HCG does. And it turns out that men do produce HCG. It's not just the pregnancy hormone. That's what we thought it was, but men actually do produce it. It decreases triglycerides. It improves insulin resistance and improves body fat to waist ratio. So basically, what it does is whatever testosterone does, HCG will do. Okay, without, and again, you don't get the sperm and prostate issues with this also. The problem here is that it's an injectable and it's expensive. And you get no changes in homocysteine, C-reactive protein, and the lipid profiles. Okay, basically, and then this is a way to measure, if you measure LH, if it's greater than 5, the HCG probably won't work. And if it's less than 3, you'll usually get good results. And if it's in between, it's variable. So you can predict, HCG by the LH. Problem with that is getting it, guys sitting in front of you, you got HCG and Clomid. Normal, I don't routinely get LH levels on these guys. Maybe I should, but I don't know. Do you guys do that?
Measuring FSH and LH levels?
Yeah. Mm-hmm.
Yeah. Yes, sir. Yes, sir.
Okay. All right. Maybe I should. I don't know. I don't usually do that. I mean, 60-year-old guy comes in and he's got, testosterone symptoms and his testosterone's 240. I never really saw the need to do it, but maybe if we're going to use this stuff, we should. Maybe the younger guys, we should.
One of the things that we're noticing, Dr. Clearfield, and I'm so interested to get, your expert opinion on this, is that, and this is immediately applicable to, HCG, is we find that, guys who are on testosterone as monotherapy to treat, symptoms of hypogonadism or androgen deficiency, that if they're only on testosterone after a protracted period of time, there is a significant amount of men that develop a reemergence of symptoms of hypogonadism or androgen deficiency, particularly surrounding sexual function, decreased penile sensitivity, decreased ejaculatory volume for the testicular remodeling, decreased strength and force of erections, decreased libido and vitality. And we find that adding an FSH and LH mimetic like HCG, as one example, mitigates those symptoms.
Right.
And prevents them from negatively impacting the patient's quality of life. So we find it becomes a very, very useful tool, because we've gotten a lot of patients that come from other practices that says, yeah, I mean, I've been on testosterone for 4 years and all of a sudden these damn symptoms are coming back. And why is that? And
do you just add the HCG, or do you like substitute?
Oh, no, add the HCG. We add the HCG.
And you do the full dose, or like these mini doses like we do for semen and,
start them out at 25 units, 250 micrograms twice a week.
Right.
Up to 500 micrograms twice a week, and it usually does the trick.
Yeah. Okay. So that's that's the dose for semen volume. We do it so if they're on an injectable, we do it on day 6 and 7 of the injectable, and 250 units. And if they're on a gel every 3rd day, we do it that way. As a standalone, 3,000 I use sub-Q every 2 weeks, or which I don't do that anymore. 1,000, I'll do 3,000 as a loading dose, and then 1,000 to 1,500 twice a week. Okay, I don't know if you have doses that you do that different. So you can develop antibodies to it. So you should be like 2 months on, 1 month off. So
yeah, that was a question. Do you find that particularly the older men, that there's this idea, or certainly it's been reported in the literature, I guess, in autoantibody formation, to HCG, and then developing a tachyphylaxis, to it. But at these lower doses, 25 units to, 250
Yeah, you
micrograms.
don't get it with that. Yeah.
Right.
Right. So you got to balance, you got to get enough to,
Right.
right. So these are the side effects that are listed in the package insert. Quite frankly, I've never seen any of these. And, we've used HCG for, weight loss, program too, continuously 250 unit, to 500 units, every day. We did that for a long time until the FDA told the compounding pharmacies they couldn't compound it anymore. Again, the land of the free and the home of the brave. So anaphylaxis, water retention, blood clots, intracranial lesions, redness at the injection site, that happens. Acne, that would be, the testosterone levels go too high. Hypertension, that would also be if the testosterone levels go too high. Also water retention, that's a, an extreme testosterone side effect. Again, package insert says don't use with prostate cancer or other androgen dependent neoplasms. I think that's probably out the window anymore. And don't use orally. Okay, don't swallow it. It has benzyl alcohol in it. Okay, so I always like to use, when I first started out here, I got a job with a company out of Florida. They send me patients and I evaluate them, and they it's called Andrologics, and they sort of use their own. They have their own formulas, and they dose really high. They'll give patients 250 milligrams of testosterone twice a week, and then oxandrolone and nandrolone, and at really high doses. And they when I first started, they sent this guy. He was about 75 years old and really frail. And he had a bad heart, and he had the diabetes and whatnot. And I did my thing, and I sent it to them, and they send back what they always send me back what they want to treat with. And man, it looked to me like that this was way too much for this guy. But I just started with them. They'd been in business for 15 years. I figured, well, they know what they're doing more than I do. So, they want me to just say, okay. So I did. Not 2 weeks later, he came back. He was bright red. He was all swollen up. He was having trouble breathing. His blood pressure was 200 over 120. We sent him for his hematocrit was 65. his testosterone level was like 2,400 and something.
Holy
2 weeks. So so ever since then, I said, you know what, my instincts are pretty good. I knew this guy was going to be overdosed. So we were able to reverse everything, but it was just way too much. They make their money by doing the compounds and selling it to the patients. That's kind of what they do. So sort of not unlike Senengenics, I guess.
Are they still in existence? I think they are, huh?
Senengenics, yeah. Mm-hmm. And here is this. This is I kind of poached this from my non-hormonal lecture. Here's 19 ways to increase testosterone without using testosterone. So high intensity interval exercise, high protein, healthy fat diet. And the protein really needs to be animal protein, unfortunately. I gave this talk. I gave this talk just the other day yesterday, to the traditional and global webinar, international webinar, the 10th annual, which is they have three a year, but they call it annual. And exactly, well, they had a big crowd this time. They had 14 people on it. It's only the speakers. The guy who runs it's out of India. And I did this one, and man, they did not like the animal fat protein. I said, if you want to increase testosterone, that's the point here. I said, I'm not endorsing animal fats. I'm just telling you that if you want to use, if you use plant fats, you're not, or plant protein, you're not going to raise testosterone levels. That's the whole point of this talk. And they wouldn't accept it. So,
Wow.
it is what it is. So, but in the 1990s, which is an ancient history already, I guess. If we told people that eat avocados and olive oil and coconut oil, they would have had your head, right? That was all taboo.
Yes, sir.
Okay, so stress reduction techniques. So whatever's a stress reduction technique for you, if it's going to the Mustang Ranch, which is the legal brothel here in Nevada, in Reno, or outside of Reno. That's a stress reduction technique. Yoga, Tai Chi, meditation, reading, running, whatever's for you. It's, wrestling with your dogs.
That's right.
Right. Adequate vitamin D. We already talked enough about how to get there. 50 to 80 nanograms per milliliter is our sweet spot. Adequate sleep. Boron will reduce the sex hormone binding globulin by about half, usually within 4 to 6 weeks, 3 milligrams per day. You can go up to 9. The books actually say 10, but they come in 3 milligrams, so you don't want to use a third of a pill. So that you can go up to 9 milligrams if you have to. I don't think I've ever done that, but the books say you can. Magnesium, 10 milligrams per kilogram per day. DHEA will drive your body to make testosterone. Remember, DHEA and pregnenolone are the precursors.
Yes, sir.
And it will increase free testosterone levels and prevent the decline, during exercise. Ashwagandha, you need and increases LH, and it will increase testosterone, but you need enough of it. Most of the supplements don't have enough. You need 300 milligrams twice a day. And so, if you're using supplements, the adaptogenic herbs that have ashwagandha in it, usually they have 50, 100, they're all a little different, but you need enough. Okay. If you don't get enough, then it's not going to, at least for this purpose, then you're not going to get what you want. And when we get to thyroid, you'll see that ashwagandha at this dose will increase thyroid levels by your T3 by about 40% within about 8 weeks. But again, you need 300 milligrams twice a day. Shilajit is a Ayurvedic herb. It's in a number of different supplements. The one that we like is called Testoplex by Zymogen. It's like a souped up. What's the one from GNC they always advertise? It has Tonga-Ali in it. I don't think that works all that well, but this one does work pretty well. Increases free testosterone, total testosterone, and DHEA. Mucuna pruriens actually works with neurotransmitters, increases testosterone levels and sperm count and motility in infertile men. It reduces FSH and prolactin levels, and you get improved sperm count. Tonga-Ali, that's the one. It's the GNC one. They advertise it all over. Something male. You probably heard the radio commercials or TV commercials. I forget. So, it allegedly increases total testosterone and free testosterone and decreases sex hormone binding globulin. Quite frankly, I've not had a lot of good luck with that. Myomin is a Chinese herb. It comes from Qi Industries, and that acts as an aromatase inhibitor and will raise testosterone levels. It lowers estrone, estradiol, and PSA. That's a pill, and that works pretty nice. It's not that expensive. We've used that quite often. We have that in the office all the time. We've been using that for about 10 years. Zinc, as we talked about, 30 to 50 milligrams in zinc picolinate. Zinc sulfate, you need a higher dose, 250 milligrams, as you see here. Pomegranate juice will increase testosterone levels by 24% within 2 weeks, 300 milliliters a day. I don't know, how much is that?
300 cc's a day.
Yeah, how much is that? That's a couple glasses, right?
Something like that, yes, sir. Now, can you use these remedies, Dr. Clearfield? Let's say you have a person who, let's say, just throw a number out there, they're on 150 milligrams of testosterone a week, and they're still having some breakthrough symptoms of androgen deficiency. They come back to you,
Yeah, sure.
10 weeks, they say, I feel better, Dr. Clearfield, but I'm still having some persistent symptoms. Instead of increasing their testosterone, can you add these
Sure.
remedies?
Absolutely.
Okay.
Yeah. And some of them, as you see, are pretty simple. Pomegranate juice, you can get that, in a supermarket. Chrysin is a aromatase inhibitor. That's pretty common. Pumpkin seeds are common. Selenium and N-acetylcysteine. It will increase testosterone, sperm count, and normalizes sperm motility. And as you know, selenium is necessary for thyroid function also. So here's 20 ways to raise testosterone without using testosterone. And yeah, you can mix and match them. Okay. The ones that we like I said, we always measure sex hormone binding globulin. So boron, we do use that quite a bit. We do use ashwagandha. I get it as a separate entity. And Shilajit, like I said, comes in a supplement called Testoplex from Zymogen. So those are the ones that I use. Zinc, we recommend quite often also. So the cheap one would be pomegranate juice. And again, you have to tell them not juiced cocktail, not ones, it's loaded with sugar. It's got to be the real deal. So, okay. This is a chart that we have. And then if you want, you can print it out. It's got the doses there and what the remedies are. So I don't know if you have a cheat sheets in a desk drawer. I do. And so,
no, that's awesome. No,
yeah. So I in that we did that lecture, didn't we, with the spotlight on non-hormonal remedies, and so I had made a chart like this for every hormone to raise and lower it. So, yeah. So what tests to use? Total testosterone. Usually you'll get a free with that. We like the sex. We get the sex hormone binding globulin, and we do that a free androgen index. There are websites. Just type in bioidentical testosterone calculation, and you can just plug in the numbers. You need an albumin with that. That's probably supposed to be the most accurate. You're supposed to get the testosterone levels before 10 a.m. You're supposed to draw the blood levels before 10 a.m. You need, if they're doing an injectable, you need to have them take their last dose, take the blood test at least 4 days after the last injectable dose. If they're doing it twice a week, then you're just going to have to do it like the morning of the when they're doing one of their twice a week doses, but before the injection. So the serum tests are really volatile, and if they're on pellets, they're not accurate at all. You really need to go by either symptoms of excess or deficiency, or do a saliva test, or you can do the Dutch test, as you know, the urine test, but that's pretty expensive. The saliva test you can get for about $130, just a bare minimum. The Dutch test is what, 300 and some. So, the insurance companies, especially if they're young guys, they want 2 lab tests under 3, and then the total has to be under 300. And if they're 301 and they have every symptom, they don't care. So, and as I get further and further away from insurance issues, now all I deal with is pre-authorizations for this and that. Every day I get letters from insurance companies. This is authorized, this isn't. And they all go in file 13. I don't really care. If the patients need help with it, I try. But testosterone injectable is $20 to $30 a month. So we're not wasting our time on that. Check the LH for secondary causes. And if it's low, you need to see if there's got a pituitary axis issue. And semen analysis and FSH to rule out infertility, DEXA scan for hypogonadism. if the total testosterone is less than 150, remember when we talked about depression, less than 150 is that's sort of the witching hour for depression associated with low testosterone. If it's less than 150, you need, again, check prolactin. We'll do that on everybody, and a pituitary MRI, and chromosomal studies, if indicated. So we had, just as an aside, we had a gal come in about a month ago for just routine. She's 42 and she's starting to get menopausal symptoms, and so we do our thing. We can do the blood tests ahead of time now just to try to save some time. Her prolactin level was 140, and her most of her hormones were normal. So I repeated it and I got 120. So, and I kind of hate that, because there's something not good going on there. And so turns out she has a pituitary adenoma. It's very small. I sent her over to the neurosurgeon, and he said there's too small for him to operate on. So we have her on Dostanex now twice a week. But that's something that if we didn't do our, prolactin levels on her, it would have been another probably 5 years before the thing grew large enough for her to start noticing symptoms and someone actually to pick up on it. So that's the kind of stuff that we can do that the real doctors don't. So just kind of keep that in mind. Total testosterone replacement. 25-year-olds, we've gone over this, about 4 to 12 milligrams a day, so an average of 28 to 80 milligrams per week. So when we're doing our 200 milligram IM shot, you're actually giving patients at a minimum almost 2.5 times the physiologic dose. And so you're going to get elevated estrogens and dihydrotestosterones. This is a testosterone replacement therapy. This is a chart. So at the top is clomiphene. And then these are some commercial products. Androgel, 1%, 1.62%. Have you used these at all?
No. Other than we use one cream. It's a 20% cream for men and a 10% cream for females.
Is that a compounded one?
Compounded one, yes, sir.
Yeah. Okay. Yeah, that's what we do. But Androgel is 1%. I mean, that's a female dose. And then I remember when I had a TV and we could say, oh, no, we got the new big dose now. Here's the big one, 1.62%. And again, they're happy if the testosterone levels are 320 or 350, as you can see here. Testim is just sort of a plain cream. I don't think that's available anymore. And that's a 1%. And then cypionate, ethionate. So again, cypionate, what happened here? So cypionate it's got a 12-day half-life. Ethionate has a 10.5-day half-life. And then propionate has a 36-hour half-life. Dr. Gordon likes to mix propionate with cypionate. So you get a short-acting, you get a sort of a shorter-acting boost and a little longer-acting effect. He uses lower doses. He uses these doses here, 40 to really 80 milligrams for males and 10 to 30 for females. And he'll put in about 2 cc's of the testosterone propionate with 8 cc's of testosterone cypionate. He'll use that as a blend. So he'll also throw in some clomiphene twice a week also. There are some newer ones out. There's pellets. We've talked about that. The Trochets, I've never used them. Again, we were always taught the oral stuff, goes through the liver and causes hepatotoxicity. There's a couple of newer ones out. There is an oral one that was just approved within the last year. It's called testosterone undecanoate, and don't confuse that with the injectable form. That's an oral pill that they say gets absorbed in the lymph. This is from the drug company, into the lymph system, and it bypasses the liver, and they do not get liver involvement. That's what they say. And as you know, you can sometimes believe big pharma as far as you can throw them, but that's what they say. There's a nasal spray called Natesto. which is pretty effective at getting blood levels pretty quickly. But you have to use it 3 times a day, and you get nasal stuffiness, and it's pretty expensive. I mean, the Undecanoate pill and the Undecanoate and the nasal spray cost about $800 to $1,000 a month. And insurance, and then all that insurance is issues. Onset of action, pellets, you'll get an effect within a week. Usually 4 to 7 days. That's the best you're going to do. The injectables take 4 weeks, and the creams take 4 to 8 weeks. I remember I had this guy. He was actually a friend. He was a fellow dancer. We always went to the group dance classes together, and he came in and he was very depressed. He was well educated. He was a geologist, and he was about 60. He was in his early 60s, and he had all the low testosterone symptoms, and he elected for the injectables, and he was very depressed. And I think his testosterone level was about 130 when we started the total. And he would come in to get the shot. He didn't do it himself. And he'd come in the second week, and I'm still depressed. He came in the third week. Well, I went to my doctor, and he gave me Prozac. I said, it takes 4 weeks. And so he came in the fourth week, the exact day, the fourth week. He says, man, I feel great now. I said, your doctor's going to tell you it was the Prozac, but you've only had it for a week. And it takes 10 to 14 days for that to take effect. He goes, I didn't take it. So I said, I told you, it takes 4 weeks. What did I tell you? Right? So it takes 4 weeks. The creams can take up to 8 weeks to take effect. And, sometimes even the compounders that we use, sometimes I don't know if they get either a little lazy or when they get squeezed a bit. We've had them sometimes use it looks like Vaseline, and as a base. Sometimes they'll do that, and it doesn't get absorbed. So you gotta look at what you have to tell the patients to bring the cream in so you can take a look to see what they got. Vaseline's pretty well, you know what it looks like. When they use that as a base, it's pretty obvious. So they need to use a hypoallergenic absorbable base. Mucilox is one. Vera, something with a V is another one. I'll have to get that for you. Again, methyl testosterone, we don't use that. It's hepatotoxic. The sublinguals wear off quickly. You have to do it a few times a day. And the commercial products actually are pretty weak and expensive. We like the compounding products if we can get them. We do use the injectable. We use the commercial products for the injectable, even though they're synthetic. The VA here, they're getting better. They got a newer, younger endocrinologist. The old geezer, when he would give testosterone, he would use it. He would actually dose it every 4 weeks. So as you know, they were starting over again each time. He did towards the end before he retired. He got it down to every 2 weeks. You need to do it within 7 to 10 days. Remember what the half-life are. You have to look at the half-life of what your product. And we just talked about that. Ethanate is about 10 and a half days. Cypionate is 12 days. You get less estrogen conversion with the injectable, and you get less estrogen conversion. Less estrogen conversion with a biweekly shot. And you get a better blood level. You get more steady. You don't get sort of that surge, and then it falls off at the end of the week.
I have plenty of patients that when I still have those issues with, I have them microdose with testosterone. So, take the total amount of testosterone they're getting a week and divide it by 5 or 7, and that's the amount they give themselves in an insulin syringe.
Yeah, I'm going to that more and more either. I was pretty impressed with the semaglutide, so I've been trying it with other things too. So we'll report back when we have enough information, but we've been doing that too. I've actually been doing it myself.
Did you hear that tirzepatide has just been approved by
for weight loss? Yeah. Yeah. And erythrocytosis is much more prevalent, almost 45%, according to the literature. 43.8% of the patients on IM injectable testosterone will get erythrocytosis, versus about 15% on the creams. So just keep that in mind. Okay. Now there's an injectable testosterone on decanoate, which has a long half-life. It's a 12-week half-life. It has a hydrophobic chain and a castor oil carrier. The way to dose it is day one, you dose it, and four weeks later, you do dose number 2, and then every 10 weeks after that. There is a risk of pulmonary oil microembolism, and again, it's $800 a shot. So the first month you have 2 shots, that's $1,600, and then you have five shots a year after that, so that's $4,000 a year after that, versus $20 once a week, it's $20. So do what you want, I guess. There again, the half-lives of the other types. And if you do use the testosterone on decanoate, the patients have to stay in the office for an hour, or a half hour rather. That's not for home use, by the way. They have to stay. You have to monitor them for pulmonary embolism. So I don't think that's something I really want to deal with. $800 a shot, pulmonary embolism risk. Do we really want to deal with that?
Not
really. I don't know about you. Testosterone cypionate, again, you can put propionate in it. You can put anastrozole in it, and even HCG. You can put zinc in there as a natural aromatase inhibitor. But again, we use it, in pill form. It's really inexpensive, and half to 1 tablet, 1 milligram pill a week is usually enough. But you can get it as an injectable. You can also get the testosterone pellets made with anastrozole also. And of course, that the big push by some of the more louder voices, that you should just let the estrogen levels run and don't worry about it. But I don't agree with that. So adverse effects, and again, same thing with any type of testosterone, mood swings, variability in libido, sexual function. The problem is you get if you do a whole dose, like 200 milligrams a week, once a week, you get a surge, and then it falls off by the end of the week. Sometimes they forget, sometimes they lose it, some they go on a trip, and so you get uneven blood levels. We always talked about erythrocytosis, and that it's not polycythemia vera. It does not cause blood clots, heart attacks, or strokes. Testosterone does not cause prostate cancer. You can get acne if the doses get too high, or if you're sensitive. I've not really had anybody complain of a non-productive cough. And of course, you can get the estrogen excess symptoms. Pellets. Now we used lower. No, this is actually a conservative number. I've seen Vexapel and the BioT people use 2,400 milligrams a day, sort of as a baseline. They have some sort of website. You put in you put in a bunch of numbers. I think again, the sex hormone binding globulin, and I guess they figure out a bio available testosterone, and the website will give you the quote unquote proper dose. I've done it. So my PA actually was trained by them, and she has the website. She pays $950 a month to be a member of Vexapel. And then she pays them every time she does pellets. She pays for the pellets, she pays for the kit, and then she pays them a fee for every one that she does. So they're doing good. But I've done it about a half a dozen times. I've told her, okay, this is the dose I would use. She put in the numbers. I think I was off by 12.5 milligrams once or twice on the testosterone doses. So I don't think, or the estrogen dose. Well, no, it was the testosterone dose. I've been pretty much spot on, just just the way we do it with our weights. And lower doses, I think, are better. On average, you can the way you can sort of judge it is for guys, 10 milligrams a day they'll use with a pellet. So 1,200 milligrams should last 120 days. That's 4 months. 1,400 milligrams, that's 7 pellets, will last 140 days. I don't think at the higher doses it lasts longer. Like, according to that, if we use 2,400 milligrams, it should last 240 days, but it doesn't work that way. But we're pretty close on that as far as how we do the pellets. For women, it's about 1 milligram a day. And so if we do 150 milligram pellet, that should last about 5 months. Okay. This is here's the clomiphene again. Oh, you know what? I got a repeat on this, so I don't know. I must have copied this somewhere. It's the same thing. Oh, okay. So now we're going to put it all together. Okay. This is kind of our overview of what we're looking at. So we're going to look at chronic inflammation, nutrition, our hormones, and mind-body techniques. Okay, so I have a nice handout that we use for the patients. It makes it easy. Otherwise, you could spend days with them doing sort of mind-body stuff. Here's our lab studies. This is what we do to begin with. I think I've sent you those sheets, right? You have those sheets, our sheets. But this is everything that we do. Again, a little bit old. I don't routinely do the 4-point cortisol saliva test unless we're not getting anywhere. We use the reverse T3 as a proxy for cortisol. So we use this. If we're not getting anywhere, it'll tell us when to dose our adaptogenic herbs or cortisol, and then you get AM and PM cortisol. So
how are you correlating the AM and PM cortisol with reverse T3? Are they pretty
I think the reverse T3 does a fabulous job. And again, I don't do these routinely here, the AM and PM cortisol. I'll get them sometimes if they come from another patient. I'll look at a reverse T3 and I'll get 21. We want it under 15, and then they'll send me an AM cortisol of 30. So I think it correlates about 90 to 95% of the time. Sometimes if they have diabetes that's usually the other reason for an elevated reverse T3. But if they have high reverse T3, invariably if they have diabetes, their cortisol levels are going to be off. So, right?
Yes. So I'm curious. So what is your trigger for an abnormal reverse T3 level where you then are then planning on implementing adaptogenic support?
Right. All right. So the numbers 15 or greater, right? Or symptoms. Some patients, very few patients will have no symptoms with a reverse T3 greater than 15. It'll happen once in a blue moon. And if it's close to like a 15.2 or 15.4. So remember what the symptoms are. They wake up in the morning, they're tired. In the middle of the morning, they need something to keep them going. Coffee, tea, Red Bull. In the afternoon, they need a nap. By dinner time, they're exhausted. 8, 9, 10 o'clock at night, they get a second wind and they're wide awake, and then they have trouble sleeping, and there's usually sugar or salt cravings. Those are the questions I ask. And, especially new patients, they come in the first time and I ask them that, and I ask them that, and they look, when they have it, they look wide-eyed. It's like are you like stalking me, like waiting outside, looking outside my kitchen window, watching me? So, because nobody ever asks them these questions. I know I rattled through them. If you need me to write them down for you, I will. Okay.
If you sent that to me, sir, that would be wonderful.
Yeah. If you look in the steroidogenic pathway, if you still have the video there from Sam Cart, it'll have the literature underneath, the download. It'll be in that download. Okay.
Okay.
If you can't find it, let me know. I'll send it to you again. All right.
Okay.
So, okay, and advanced lab tests. And I've been kicking around. I know some people do this. I've been kicking around putting together just a bundle and saying somebody comes in with, say, low T or Hashimoto's thyroiditis. And I said, okay, we're going to do all these tests. We'll just do them all, and we'll find out what we can. I mean, now I try to, tease them out so we don't do things unnecessarily. but a lot of times, I mean, we end up doing this. So food allergy testing, IgG delayed, functional GI test. We like Genova's, or we've been using GI map lately also. SIBO, if the GI function test doesn't get us anywhere, we'll do a SIBO test. Lyme antibodies, and then mold and mycotoxins. And I don't have one here. We've actually been using my myco lab, and so Dr. Andrew Campbell's stuff. You know, he does not like urine tests. He does not like binders. I don't know how you're going about it. He gets the IgG and IgE antibodies in my myco tests, and I'm getting pretty good at it. I the last 9 tests that I've done for his test is $380. It's not cheap, and it's a serum test. The last 9 tests, 8 of them have been positive, so I'm getting better. I'm getting better at picking it out.
Wow.
And we can go over. Did we go over that? And the remedies and stuff. So
No.
we can do that too. Here are the calculations. I think we showed you these from time to time. We get a free T3 divided by the reverse T3. And what I do with the free T3 is I multiply it by 10. That's just to give us even numbers. And you really want it over 2.0. Okay, so it's the testosterone cortisol ratio, and you really want it over 2.0. This is Dr. Gordon says over normal is 1.06, but that's really not high enough. Anything under 2.0, you're going to have symptoms of cortisol, excess or deficiency, and you're going to want to do something with that, even if So if the free T3 is like 2.0 and the reverse T3 is 13, so 2.0 times 10 is 20 over 13, so that's like 1.67. They're going to have symptoms, okay, even though it says 1.06 is normal. It really isn't, okay? So elevated reverse T3, 90 to 95% due to cortisol. And here are the other issues: B12 deficiency, diabetes, and low iron.
Are you doing this calculation when you're just looking at the free T3 to the reverse T3 to
I actually have it on that colored sheet that I've showed you before. I actually have it on there, a place for it to do the calculation, to put the answer.
Oh yeah, I'm sorry. I meant just if you're deciding whether or not to begin adaptogenic support.
Again, I'll ask them the symptoms. If they don't have symptoms and they have a lot of other things going on, I'll probably leave that alone. If they have symptoms and the numbers are greater than 2.0, most of the time I'll tell them, well, we're going to do this for a short period of time, like 3. So I have them back in 3 to 4 months, depending on, or even 2 months, depending on the severity of their case. I'll tell them that it's probably just a short-term thing. It's not a permanent thing. And a lot of times that's all it takes, especially if you have a low reverse T3, but you have like that low T3 syndrome. So usually 3 months is all it takes to straighten that out.
Are you considering this this calculation, or do you ever just go by the reverse T3, that number by itself, for adaptogenic support if they have symptoms, or are you always wanting to factor in this free T3 to reverse?
I look at both.
Look at both. Okay.
I look at both. Okay?
Is there any conditions where you have a normal ratio, but an abnormal reverse T3 with symptoms? Does that ever come about?
Yeah. You can have let's say they're either hyperthyroid or close to hyperthyroid. Let's say they have a free T3 of 4.3 and a reverse T3 of 12. Okay, so that's 43 over 12. That's 3.5. So that would be normal, but they have every symptom of cortisol issues. They have all of those symptoms.
Yes.
So okay. Symptoms rule, really. I mean, I use the numbers to back up what I'm doing, or to
right.
get I can show the patient, here's your numbers, here's this is the normal, this is the abnormal. You have these symptoms. Technically, the numbers don't show it, but if you have it, you got it. Same thing with when we do pregnenolone. Like my pregnenolone level was 0. Do I think my memory's bad? I mean, I have trouble with names, especially like supplements and whatnot. Sometimes it'll take me, or even people, it'll take 30 seconds to a minute for it to come to me. You've seen that here. I've done that many times here, right? But do I need pregnenolone? Probably wouldn't hurt. But not. It depends. I take a ton of stuff, so sometimes one more is not. I think pregnenolone makes me nauseous or something, so I don't do that. This TSH index. This is low free T syndrome. Free T3. So you measure free T3, or you measure TSH, and you add 0.1345 times free T4. That's a TSH index. If it's less than 1.3, that's that's really, we got this from the brain injury people. If it's greater than 4.1, it's a peripheral issue. So this is somebody who's got a TSH of 0.8 and a free T4 of 0.9. And so that index is low, even though if they have a free TSH of 0.8, their free T3 should be 4, right? And when you get them low like that, so that's usually the issue. And so if it's high, the TSH index, it's usually an iodine selenium issue, and a too low and cortisol too high. Insulin resistance. This is, again, we've gone through these, I think, before. Fasting insulin times fasting blood sugar divided by 405. Normal's less than 2.9. Optimal's less than 1.9. Future risk of glucose abnormality. Every point over 84 on a fasting blood sugar has a 4% risk of developing glucose dysfunction within 5 to 10 years. I do this on every patient. So fasting blood sugar of 94, which is quote unquote normal, but that gives us 94 minus 84 equals 10 times 4 is a 40% incidence of developing that's a risk factor, glucose dysfunction within 5 to 10 years. And I tell the patient, I'm very clear. I say, I'm not saying it's abnormal now, but I'm saying is this is a risk factor for the future. So if we jump on it now, we can prevent, especially if they have blood sugar issues in the family. There's the reference for that, by the way. If you want to look that up yourself, I didn't make it up. Okay.
I never think that's awesome.
All right. We talked about free androgen index a lot. So serum testosterone level divided by the sex hormone gynoglobulin times 0.288. That's your conversion factor. 53 to 107, 110 is our optimal. For women, about 3 to about 6. Okay. And then where do we go here? Testosterone, dihydrotestosterone circulating in plasma, the bioavailable testosterone. This is supposed to be the most accurate. You remember the sex hormone binding globulin is only 44% of the testosterone circulating. Albumin is 54%. So the free testosterone is measured of this fraction. You put all those numbers in. There's any number of websites. I mean, we're always in front of a computer, or you can get it on your phone. Just put in bioavailable testosterone calculation, and it'll just ask you for the numbers. Normal is 108 to 500. That's again supposed to be the most accurate. This is the record that Dr. Gordon uses, and what he has is this is the midpoint of all the ranges. So you can use this as a reference. This is for males. So you can see here midpoint's about 700. This is the females. Our goal here usually total is about 30 to 40. That's where we like it to be, 2 to 4%, 2 to 4 on the free. We do IGF-1 pretty routinely. We want that to be 200 to 250. Growth hormone, if you do growth hormone levels, it has to be before 10 a.m. And a lot of times you're going to get like 0.1 and it won't get flagged. So the lab will say 0 to 5 is normal in an adult. So but it really should be, in the 4.5 to 5 range. So that's not good enough for the FDA, though. You have to do one of those stimulation tests, insulin, a glucose stimulation test. There's an oral one now, is a McCarran stimulation test. They give you McCarran, and then they take your growth hormone level and IGF-1 and IGF-BP3 before you get either the glucose or the McCarran, and then you take it every half hour for 3 hours. The growth hormone levels should stay below 5, and that's positive for growth hormone deficiency.
How often is that test, due to just age appropriate decline of growth hormone levels, is that test turning out to be positive, like in men over the age of 45? Is it pretty frequent that
I don't know. The answer is I don't know. Okay. So according to the FDA, that's what you have to do to legally prescribe growth hormone. So I know a lot of people don't, but there you go.
Yes.
Okay. Nutrition. So I did update this. So we took out the HCG diet, which we liked a lot. We put in our GLP-1 agonists. I actually have some retratitude now, the next generation one after tirzepatide. I have 4 bottles of it from Jay.
Do you really?
I haven't opened it yet. They've been sitting on my desk for a week unopened. So I'm not exactly sure how to dose it. I've been reading it. They're 6 milligram bottle, with powder. So if I dilute it with, I don't know if I can get 6 mLs of fluid in there. So I'm going to have to do a little bit of math, but yes, I have 4 bottles of it. How they're making it, I have no idea. It's phase 2 studies. I mean, it's not like it's out anywhere.
Yeah. Is it based on the data, is it supposed to be far superior?
It's supposed to be way superior to both tirzepatide and semaglutide with way less side effects. So we talked about that, right? What we've been doing to mitigate the side effects, and we talked about the fresh ginger and all.
Right? Yes.
Have you been getting your patients to do that?
No, just only because we really haven't had a lot of side effects. I usually we're giving a lot of patients a lot of them have been on BPC 157, and they are separately, and we do use antiemetics every once in a while, but haven't had a lot of protracted cases where they are, where they have a lot of protracted nausea, vomiting, GI symptoms. Usually, I'll stop the medicine for a week and then restart them at a reduced dose, and then slowly bring them back up. And they usually, recover. But those remedies are very, very, I'm sure they're very effective, and I need to start.
Yeah, we've had, I can't think of the last time somebody called and said they couldn't take it. The only ones who call now are the real neurotic ones. And they don't want to pay for it. So basically, but I haven't had anybody call and say they can't take it, in the last 3-4 months since we've been recommending the ginger. So are you using the BPC orally? Is that what you're doing?
Yeah, BPC orally, yes. Now and getting really good results with that, as well as the the injectable.
Where are you getting the BPC from? And
New BioAge.
Yeah, well, I don't like them anymore. This business that you have to belong to their club for $200 a month. Screw that, really.
Yeah, I know that you don't. Did I send you? Hayden Collier's mobile phone number and contact number? He's one of the chief compounding pharmacists there. Super guy. You definitely don't have to be a part of that subscription. I think they're trying to really reach out to new clinicians who really have no idea what in the world they're doing, and kind of want some guidance. But the experienced experts like yourself, you just order as normal. You don't have to deal with any of that stuff. So But that's just an extra, program that they're kind of offering,
Yeah.
So
Yeah, you're stuck in a vice and we're going to stick it to you. That's what that program is.
that's true. Yeah, that is true. But he made it clear to us that you don't have to belong to that program. I mean,
Well, you're part of Vikings, so you got what, 400 doctors in there or practitioners?
no, there. We have about 10 now, 10
All right,
providers.
so I'm sure you guys are writing a hell of a lot more BPC than I am.
Oh yeah, a lot, tons. Yes, yeah, a lot.
Okay, so those are the sort of the nutritional program. We have that BioSite program we use.
Oh my goodness, one of the um, uh, tremendous. I thought Sam was going to give you, raving review. We're just so grateful that you made that recommendation. We're kind of using that a lot for patients.
Yeah, it makes it easy. They have a terzepatide and a semaglutide sort of what to do program in there. I don't know if you've seen those. So I use that. It runs for 70 days, and then I usually put in you can add in another program. So I usually do a paleo or a keto after that. So it runs for 3 months. So that's what we use. That saves a lot of time and money. And okay,
You
the
know what?
hormones. Um,
I'm sorry.
so here's my summary of the hormones. It gives you function and symptoms of deficiency, and also the doses here. Okay, so this is everything you need to know. Everything I learned in the last 20 years on hormones is all on this page. Right? You don't have to know anything. Here it is. Right? It's on this page, and then it runs onto the second page here. All right. So anything you need to know, here it is.
That's awesome. Do you have the nutrients there as well, or
Oh,
do you have the supplements there as well? Not on that one.
no, not on that. That's the hormones themselves.
Okay.
Okay. The supplements are in that. Did we do the non? It's called Spotlight on non-hormonal remedies.
I don't think we covered the a separate lecture on that, but
Yeah. Yeah. So that was the other lecture I did at AMMG, and at the end, you saw that one chart that I had for testosterone. I have it for all of them.
Oh, that's awesome. Could we do that next time, Doctor?
Sure.
Okay.
All right, so a couple of cases. They wanted cases too. As you can tell, I think I had an hour and a half for this one, and as you can tell, I didn't get this far. So yeah, this is basically a 52-year-old guy. He's nothing's working anymore. He's got low libido. He's getting fat. He's getting grumpy. He's losing muscle mass, and this is our typical guy. He comes in, and we do it. Here's the labs that we do. His total testosterone is 198. His free androgen index was 18. His estrogen levels are 62, and his vitamin D is 19. You should know what to do with this, right?
Yes, sir.
Right? Not a big deal. Case number 2. Unexpected side effects from testosterone. So this guy is 58 years old. He's been on IM testosterone for 9 months. His total testosterone increased from 293 to 746. His red blood cell count went up to his hematocrit was about 54. And again, so we do phlebotomies for that. Every 3 months, every 2 months. It depends, depending on how high the blood counts go. Remember where we are, we're at 4,500 feet in the valley here. So our hematocrits are higher than you're going to be, where you are. 55 usually. And again, you really don't need, with testosterone, you don't really need to do this. I mean, it's kind of a knee-jerk reaction. The know nothings out there think it's polycythemia vera. We went over all of this. Well, you need, if you get a CBC and the platelets are normal and the white count's normal, you really don't need to worry about this. You remember the bicycle guy. Here's my pregnenolone going. The bicycle guy it took him 10 years to catch him cheating. He won all the bicycle races, and by a lot, and then his hematocrit was 70.
Oh, there's a guy that was doing blood doping.
Yeah. You remember him, right?
Right.
So his hematocrit was 70. He was doing erythropoietin and testosterone, and he didn't get blood clots. It doesn't happen.
Right.
All right. So technically, you don't need to do that. A lot of guys will say after they do a phlebotomy, they feel lighter. So,
Yeah. Yeah.
but and
I,
again, yeah, when I was in Wilkes-Barre, that's at sea level. Normal hematocrit's the 35 to 45. Here in Reno, it's going to be higher because 50 is not unusual, and somebody's just been living here for 10 years.
yeah.
Because it's a higher elevation.
I can tell you how many problems we have seen, Dr. Clearfield, with we got so many patients coming from other clinics. It is astounding, Dr. Clearfield, how many providers are getting involved in this. They have no formal training, and they're doing the most wacky, crazy, ridiculous stuff. Putting patients on a milligram of Arimidex, 5 days a week.
Yeah,
Uh,
I know.
Phlebotomizing patients every 4 weeks, and then these patients develop horrible iron deficiency anemias
Yeah, I know.
out of bed, and they wonder what the hell's going on,
Yeah,
and
I know. I always say it's better for us. Right. And I try, I never criticize anybody. I don't say, well, but a lady came in and says, well, my doctor gave me Premarin. A lady came in, my doctor gave me Premarin because I was having hot flashes. And she came in she didn't come in for, I think she came in for weight. And I said, well, I don't like to criticize anybody, but we really shouldn't use that. That's the bad guy. I don't even know why it's still on the market, to tell you the truth. But I try not to say anything. He says, well, if your doctor needs some literature on this, I can send it to them. But you really shouldn't be on that. You should be, you can get estrogen, a commercial, you can get a patch. We don't like pills, but the pill estrogen's better than the Premarin, and you can get the progesterone pills. You can get, the FDA approved stuff. You don't have to use our fancy stuff if you don't want to. So, okay, acne and oily skin is usually a testosterone estrogen imbalance. There's any number of ways to lower it. Usually the testosterone levels are too high, so we want to lower the testosterone levels. Spironolactone, as you know, will block the side effects of testosterone without affecting testosterone levels. So for guys, 50 to 100 milligrams. For ladies, 25 to 50 milligrams is the usual dose. Oil-free skin wash. Spearmint tea. Remember that? Two tea bags and 1 cup of water will lower testosterone levels by about 20%. We use that a lot with polycystic ovaries. And then there's any topical ointments. There's a Retin-A, there's Accutane if it's really bad. So that's acne. Again, your testosterone levels are usually too high. That's the usual issue there. Elevated PSAs. I send them to a urologist just out of caution. Urologist tells them they're fine, then they're fine. Mood swings and aggression. I really don't see this a whole lot. I don't know if you see road rage from testosterone. I really don't see this really at all. I mean, it's in books and all, but I really don't see it. Gynecomastia, we talked about that, how to do that if they have erectile dysfunction, we use progesterone or progesterone cream. If they have don't have erectile dysfunction, we can use a really low dose aromatase, Arimidex, a 0.5 milligram every week to 2 weeks, and anything to block the estrogen effects. Fluid retention, that's usually way too much testosterone. You have to adjust the doses. Sometimes you might need a diuretic. You probably do better with spironolactone for any side effects. And then for sperm count, we talked about HCG and clomiphene as an alternative. Okay, so that's pretty much the complications there. Prostate issues, again, we've talked about that. PSA increased from 0.8 to 3.9. Positive biopsy for prostate cancer. We talked about that in the other lecture. Studies suggest testosterone does not increase the risk for prostate progression or recurrence. Everyone's individualized, and remember that chart we had, how to, different types of treatments, and when we can safely revisit testosterone levels. The best outcomes for long-term outcomes seem to be with X-ray therapy or brachytherapy versus either surgical intervention or chemotherapy. They have the lowest incidence of recurrence in prostate cancer by 300%. But long-term 5-year outlooks, they're all the same, no matter what you do with them. So this looks like the same slide. Oh, here it is. Okay, here's outcomes. So radical prostatectomy, recurrence rate of 11%, X-ray therapy 4%, active surveillance, which means doing nothing, 10%. So you do the prostatectomy, you do nothing, you got about the same outcomes, and you see 5-year rates are just about the same. Okay, and this is a person with all sorts of, we call meshuganosis. So they have everything wrong with them. So they have a stroke, they have low T, they had a stroke, they have heart disease, hypertension, prostate issues, cholesterol issues, asthma issues. They're on all sorts of drugs. Sometimes you get an interaction with them, but on the whole, I think testosterone would actually help this guy, especially if they've had a stroke. There's usually, a brain disruption, and you'll get you'll get an anti-inflammatory effect and improved energy and strength. No direct drug interactions with these medications with the patients. You go online and put in a medication checker or interaction checker, and you can put in anyone, and there's a whole bunch of them. I can't, again, here's my Medscape, I think, has one. There's a whole bunch of them. You can put in, all the drugs and 6 different drugs, and it'll give you the interactions between them all. So it's a couple of them you can tease out, but it's pretty impossible, at least for me, to remember them, especially when there's a whole lot of drugs. So this mind-body connection, this is an 8-week program. I have a handout for it. Remind me, I'll send it to you. And it basically, once a week, we give the patients these sheets here, and we ask them to write down goals for family, spirit, education, and finances, and what they think they can do for action steps. So, and then we review diet choices, supplements. So basically what we do, injectables we'll do sometimes. This is kind of like a Myers cocktail, glutathione, and then they need some exercise. And, a lot of these people, I wrote this when I was in Wilkes-Barre, those people don't move at all. So if you get them to walk around the block that twice a week, you're doing well. We like a moment of gratitude, and we always tell patients to buy flowers. It perks up the house. So week 2, we do this every 4 weeks. We have them grade themselves on 16 different categories, and from 10 is perfect to 1 abysmal, and then they can sort of follow along to see how they're doing. And we have, I think, a scoring system. We have all these categories here: diet, exercise, life plan, work, romance, finishing what you start, children, families, gratitude, and then you can sort of add it up and just get an idea of how well they're doing, and sort of life in general. Action steps here, for diet, get rid of the bad oils, get rid of food colorings, add a protein supplement, stay away from white bread, white flour, add in some green tea instead of coffee, and then a general supplement, so flaxseed oil or fish oil, and your Myers cocktail, or MIC is a B12, folic acid, and methionine and acetylcholine injection. So it's sort of a precursors of growth hormone, or we use glutathione, 600 milligrams IV. So we put it in 5 cc. So that's 3 cc's. We put it in 5 cc's of normal saline, and we do that as a push. We charge them $20 for it. Can walk 15 minutes without stopping. gratitude, buy flowers. And then so we have this, and I actually have this as a handout. I can send it to you if you think this is something that might be of help.
Absolutely, yes, sir, for
Okay,
sure.
so remind me, I have it in a Gmail. And then I have them write a letter to themselves, pretending it's 6 months in the future. What have you done in the last 6 months to improve your life? And then I have them give it to me, and then I have them write a second one. Pretend it's 5 years from now, and what have you done to improve your life in the last 5 years, or where do you want to be in the next 5 years? And so I have them keep a copy for themselves. I tell them to put it away, and I also keep a copy. And again, 5 years is, a long time, but I have patients. I put it in a little envelope, and once a month, first of the month, I'll pull the envelope out, and the ones that are 6 months down, I'll mail it back to them with the questions. Okay. We'll meet back in 6 months and 5 years, and what has happened to make your life great, and have them write it down. So sort of a preemptive strike. Again, increasing your exercise every week. Have a moment of gratitude, and add some protein, add some green stuff, just practical stuff. Just gradually. You have to remember, I was dealing with Stada Babas there. Old Polish grandmothers. To get them to do anything different is not easy. This is goals for the next week, month, and year. And so with a family, contributing something, health and physical wellness. This year I will do this. This month I will do this. And then you just have them write it down and keep it handy. This year I will take classes with Miklos. This month I will tell Miklos he's an idiot. Whatever it is. Okay. And then finances too. So goals, and then a bucket list this week 5. And again, I did this once. Did you ever try a no news day? I did this before the internet was. I did this with a class once, and man, I think did I ever tell you that?
No,
So I did this with a group on Saturday mornings. I used to do this, and I told them, okay, we're going to do a no news day next Friday. Because again, these old people, they're sitting there watching CNN all day, and it can make you pretty miserable if that's all you wake up and you're listening to CNN and you have it on all day. It can make you crazy. So I said no news day, and then they said make it Friday, and then we'll meet next Saturday, right? Well, I came in Saturday and they were all mad at me. I said, what? She goes, didn't you hear? I said, no, I didn't want to listen to the news. I did the same thing you did. That was the day John F. Kennedy Jr.'s plane went down in the Atlantic. And so when I went home, they're showing from a ship, they're scanning the ocean looking for his plane. And that went on, come back hours later, the same thing. It took like 2 days to find it or something. I don't remember exactly. So I came back the next week. I said, if you didn't know about it until Saturday when we came in, and didn't waste your time sitting there for hours watching nothing and doing something more positive, wouldn't your life be better right now? But I remember that was like 2009 or something. I think that happened. So, okay. Action steps, week 6. I think they have on the list. Action 7. List 7, 5 things you can do to move next week to move your life forward. What's holding you back, and identify a couple of new patterns to reach your goals. So, I mean, these are, psychologists will have you do this. Dietary stuff, and then what are you going to do for the next 8 weeks? Where have you? How far have you come from when we started? There's the dietary issues, again, considered a no news day. These are the sort of general things. We do some things a little bit different. And so as far as testosterone is concerned, nearly everything we learned about testosterone in medical school was wrong. Here are the pros and cons of what testosterone does. That's a nice little chart here. Prostate cancer, high testosterone. We went through this. High testosterone levels does not increase prostate cancer, does not increase the risk of prostate cancer, does not increase the risk of progression in men, does not cause an exacerbation of metastatic prostate cancer, and does not cause rapid progression and death. Erythrocytosis, the high testosterone levels does not increase blood tumors, cardiovascular risk, strokes, or blood clots. And here are all the references for it all. Pretty good there, huh?
Absolutely.
Remember what we always try to answer. My doctor said there's no evidence of, fill in the blank. So here are the references, 123 references. I know there's more. 147 references. So there you go. I don't know, pretty complete, I think. Took us 4 sessions to get through the whole thing, but not too bad.
Awesome.
Okay. Any questions about anything?
No, it's a great presentation, sir. Thank you so much.
Okay, I will send me a text message to remind me when I get to the office, and I'll send you if I might have a little bit of time. No, I got to get going. I might have time to do it. I'll see if I can email you the at least the handout I have for that mind body thing. I don't know if you're going to use it or not, but you can look it over. There's 1 page for each week. I showed you what it was on the slides, but there's 1 page for each week, and there's recommendations for behavioral changes and diet changes underneath. It's not specific for semi-glutide or paleo diet or anything like that. You can change anything you want. Okay. But there's again, it's what do I want to be when I grow up kind of stuff.
Yes, sir.
And so, one of the criticisms, well, you're just handing out pills and you're not doing anything else. So, so we have recipes, menus. We send them with, on our the body site program. We have the mind body thing. I mean, I don't know what else we can do, especially as like a single person. There's not a whole lot, considering how how much time we have with them. So.
No, I mean, the kind of care that you're giving the patients and the comprehensive nature that you give them, I just can't ask for anything better than that. So, well, they come to you.
Yeah. Okay. I'm going to have to get going. I'll talk to you next week.
Yes,
so we finished this. You want to do, I'll put together the female bundle for you. Okay. Yes. And that'll take a while too. A lot of it we've already covered, but we can put it in an order. Okay.
Yeah. So helpful. Yeah. Putting it all together. I'm sure your students in the past have attested, and I hear it at Rousier's conference all the time, just general knowledge, that because the science, changes, that you can go through, this training, over and over again and learn something new if you really listened every time. So
well, that's kind of the whole idea. And, as I haven't, some of these slides I haven't looked at for a while, I already see some of them are dated, so I have to go back and fix them.
Yeah. Oh, and Dr. Clearfield, you were going to send that lecture on the spotlight, the natural remedies to
right.
Hormones.
Mm-hmm. Okay. You know what? Just if you could send me an email when we get off, just to remind me.
I will.
Okay. All right. I had a good time. So, as always, say hello to your lovely bride. She should be needing Botox again. It's it's been more than 3 months.
Just talked about that. She said, "When are you going to inject me?" I said, "When Dr. Clearfield has some time and I can do it in front of Zoom with you in the chair." So.
All right. I don't know if you want to come to. I don't know if you want to come to Reno in the winter though, unless you want to go skiing.
Oh no, we're gonna. I need to come and see you on a regular basis. I desperately need that. That training and.
I don't suppose you're going to make it to A4M in Vegas next month.
Yes, I am. Yeah.
Oh, you are. Okay. So I'll be there. We definitely have to hook up. Jay Campbell's going to be there. He said he's taking me to dinner, so take you with. Halas is trying to arrange a meeting once, so it goes like Thursday to Saturday. He's trying to arrange a conference meeting for us, rogues on Sunday there. So I'll let you know about that. Okay.
I think he's strategically surrounding himself on developing a cadre of physician experts. He's
Yeah.
method to his madness. So that's good. That's
Mhm.
good. That's just
Okay.
good.
All right. So I can't wait. Is Tina coming with you?
I don't know. She has so much going on with teaching and with school, so we'll see. I certainly, always want her to come with me, but
All right.
so I just don't know quite yet. But I'm taking that board certification exam there.
Oh, okay. All right. So you're going to be board certified.
Yeah.
All right.
So,
So I hope you're smarter than me. It took me 5 years after I got my board certification when I had an idea what was going on.
I'm light years behind you, sir. I'm so grateful that
No, I don't think so. I think you're doing fine. Okay, I got to run.
all right.
I
Thank you
will
so much.
talk to you later. Send me an email. Just send me a text message to remind me because
Okay.
I gotta get ready here, and I'll do my best to get this to you. Within a day or two instead of a week, like I usually do. Okay.
Okay. That sounds great. Thank you so much.
Okay. Thank you, sir.
All right. Take care.
Bye.